So I'm going to be talking about the work that we're doing with the World Health Organization in developing measures of the behavioural and social drivers of vaccination. And this is why it's important. If you were just consuming the news media, you would be forgiven for thinking that the only cause of low vaccination coverage is the anti-vaccination movement, is negative messages about vaccination. And we get regularly exposed to this attribution in the public arena. The logic of it goes like this, that anti-vax messages reduce acceptance, which reduces coverage, which causes outbreaks. And certainly hesitancy is a problem. We've just heard about the problems that the Philippines has experienced with it. WHO have named it as one of the top 10 threats in 2019, but they also named fragile health systems and weak primary care. And those things both influence vaccination uptake as well. If you look at measles cases in the last 2 or 3 years globally, the countries that have had the biggest hotspots for measles, i.e. the biggest number of cases, have experienced sometimes both a mixture of hesitancy, lack of acceptance, and sometimes major disruption to their healthcare systems, like Venezuela, underserved regions like in Brazil. In the Ukraine, they've had a mixture of hesitancy and inadequate services. In Yemen, children have been affected by conflict and displacement. In Madagascar, where the largest number of cases were, there's a weak health system. And in the Philippines, they have had many years of inadequate immunisation services, and then they had the compounding effects of the vaccine safety issue. So measles is complicated, and we have this problem globally where vaccination coverage rates have stagnated. And they've been sitting for some years at around 85, 86%. And there remain many, many children who are not reached either at all with vaccines or are under-vaccinated. What's causing that gap is an important and empirical question. And measurement is going to help us understand that gap. And I mean measurement broadly, as you'll see in a moment. Some of the issues with the current messages is that they tend to focus on attitudes, the way we think, the way we feel about vaccination, less on the practical and logistical barriers to vaccination that also influence uptake. Some are validated, some are not. There's not great standardization. There are some efforts that are being brought in where they're able to look at changes over time, which is a great development, but generally surveys are done differently and they're not standardized. We're caught in this binary notion of we've either got a supply or a demand issue, which oversimplifies it, and the findings are often not used. So essentially with measuring that gap and the causes of it, the answers you get are as good as the questions you ask. So the WHO, along with the Demand Hub, have initiated an effort to develop globally standardized tools to measure the behavioural and social drivers of vaccination, BeSD, I'll call it BeSD. And this is part of measuring different components of vaccination coverage. You want to know what the coverage data is like, the surveillance, what the disease burden is like, what how the program is performing, such as with supply, wastage, policies, and you want to understand the behavioural and social data as well. And this work sits under the work of the Demand Hub, who are a combination of these organisations on the right, and it sits at the bottom in social data, and it relates to tools for gaining social data. So the objective of this effort is to boost the availability, quality and use of local and global data on acceptance and uptake that will support assessments of under-vaccination, so understanding that gap, will inform the design and evaluation of interventions, will track trends over time so we can see if there is actually a decline in vaccine confidence, for example, and contribute to regional and global reporting processes. What are the tools? There are three things. There's a survey, which is called the Childhood Immunisation Survey. It's intended for parents or caregivers to help understand their perspective on what might be contributing to their child being under-vaccinated or what's influencing them to get their child vaccinated. It's 22 items long, i.e. questions or statements that people answer. And we have a short form, which is 5 items. We also have in-depth interview guides, which allow you to dig deeper into the perspectives of caregivers, but also immunisation providers, community stakeholders, and authorities working in immunisation systems. So we're getting that sort of more upstream perspective, and a user guidance that's informed by user design thinking principles, where we're thinking about the personas of a vaccine program manager and a field researcher and what they need to know to be able to use these tools well and then act on them. Now, the challenge with developing something like this is that you have multiple contexts in which you're trying to fit a single set of measures that will suit many, many different delivery contexts, provision contexts, poverty contexts, access contexts. So it's been a challenging process, and to develop quality tools takes time, as any of you know who are developing measures. We're starting with this assumption. This model, the increasing vaccination model, has been adapted from work led by Noel Brewer, and Noel is going to later talk about the model and the development of that model. In using this for measurement, we're saying that what people think and feel about vaccination will influence their motivation to vaccinate, as will social processes, the social influences, the provider, the family, the community, whether they have a role, whether there's gender equity and autonomy and decision-making of the woman in the family. That will influence motivation. And that's where we locate hesitancy. We call hesitancy a motivation. We don't call it a behaviour in this model. And then whether you vaccinate or not will be affected by practical issues, which we've distilled down to knowing where the vaccine is available, the ease of access, affordability, service quality, and respect from provider. The 2 items in bold there, we call these things constructs, and the ones in bold, I'm just going to show you a brief example of what they look like in our tools. And these are just 2 examples of them. So in the survey, the question is, in your family, who has the final say about vaccinating your child? In the in-depth interview guide, the question is, tell me about how you decided to vaccinate or not vaccinate your child or children. Who else was involved in the decision? So that's a very open question, and you will obviously analyse it very differently. In terms of ease of access, how easy is it to get vaccination services for your child? In the in-depth interview, walk me through what you do on the day of vaccination. Start at the very beginning. We've been field testing these tools. One of the countries we've done that in is Sierra Leone, where we integrated the tools into preparations for a national survey, working with Statistics Sierra Leone. We were doing cognitive interviews, so we're trying to understand how people interpret the questions in the survey so that we can make sure that the questions are phrased in the way we intend them to be understood. So we ask them the question, then we ask them the questions about the question. As you can see on the right here, the question is, how important do you think vaccines are for your child's health? And then the probes are, what were you thinking in deciding your answer? What do the words important for your child's health mean to you? And the response options, did they fit the sort of answer you wanted to give? So you can get a sense of what cognitive interviewing is here. We've been able to test the tools in both rural and poor urban Freetown and Sierra Leone. And here's just an example of one of the clinics where some of these cognitive interviews were occurring with the mums. This is a phased process where in the middle, obviously COVID has stalled our in-country field testing, so we're adapting that. We're heading into a phase of psychometric validation, so quantitative validation of the survey, further testing of the in-depth interviews, and then integration. The future plans are for, once we finish this process, hopefully by the end of the year, then we'll develop a data repository for reports from countries and tracking of metrics and indicators for global efforts around vaccination. We're looking at supporting capacity building, the data gathering for analysis, translation, but also in social and behavioural research in this field of vaccination. And we're also looking at, well, WHO are planning around feedback loops for continuous learning from implementation. And most importantly, and to finish off, I want to acknowledge the working group members. This is a group that represents many different agencies, countries. We've got academics who specialise in this area. And I want to acknowledge Lisa Menning, Secretariat at Headquarters, and Noel Brewer, my Deputy Chair, who you'll hear from very soon, and the core group, Francine Ganter-Estrepo, Gila Shapiro and Kerry Wiley, who have worked particularly hard, along with the broader members of our working group. Thank you very much.
Thanks very much, Julie. For those of us who study vaccine hesitancy, this is incredibly useful work for us to have that kind of rigor go into developing measurement so that we can tackle vaccine hesitancy. And the focus on multiple settings and the cognitive interviewing is fantastic. And look forward to hearing from Noel at the end of the session as well.